So
Yeah, I know.
we'll jump into it. So maybe briefly, if you could introduce yourself. I assume some people on the call are familiar. I know, you're a periodontist. I know you're a highly skilled periodontist. You do a lot of teaching, a lot of lecturing. You're based in Brazil. But give us the 20-second intro to Dr. Robert Carvalho de Silva.
So Dr. Robert is just another dentist out there trying to do the best, trying to use as much as he can in terms of the great materials and biologics that we have available to do the best of it for our patients. So yes, I'm a periodontist. I'm an implant dentistry professional as well. I've been working in the field for the last almost 30 years, 29 years right now. I'm as a dentist, and as I've been practicing as a teacher for the last like 20 years now. So some publications, we wrote 2 books, and our expertise is really trying to create decision trees so that other dentists can get the predictability in terms of the outcomes that we desire for all of us.
Awesome. So let's talk first about GBR. I think that's how I kind of first came to know you, is you were doing some very impressive case using our titanium reinforced PTFE membranes. I think you were showing me some cases, and the results were remarkable. So for GBR, horizontal versus vertical. I know a lot of horizontal defects also have a vertical component, so they sort of become a vertical as well. But how are you treating? How do you differentiate? Like, what's your treatment protocol for vertical, and does it change any for horizontal?
I know pretty much the real change, the real difference in terms of the treatment protocol when I'm dealing with horizontal versus vertical is the decision of the membrane that I'm going to be using. So pretty much if I'm using a horizontal defect, regardless of its dimension, even if it's like a very thin bone, very narrow bone, like knife edge, although many people that I know are using titanium reinforced, on those clinical scenarios I prefer to use resorbable barriers, because I think that we don't need to use non-resorbable membrane to treat like a horizontal defect. But when it comes to the vertical, it's mandatory to use something that can keep up the height interproximally when you think about the interproximal bone peaks, to create like a tenting effect on the middle in a way that the bone graft can stay there long enough to facilitate the growth of the natural bone inside that area. So pretty much the membrane is going to be the major difference, and the graft material, when I'm treating like horizontal deficiencies, I'm going for like 60% of autologous bone versus 40% of a xenograft, which is what we use here in Brazil. But when it comes to the vertical, through time, I've been increasing my my proportion to autologous bone like to 75% versus to 25% of xenograft. I felt that by doing that, my outcomes became more predictable and better in terms of the quality of the bone that I've been using.
Okay. So I know in like Europe, it's a lot of xenograft, a lot of autogenous. You're saying you're using kind of similar. In the U.S., I think we use more allografts, and I also see a trend in Europe more towards allograft, still less than xenograft, but I think in Europe they're starting to use some allograft, whereas they didn't really much before. Like, what is it like in Brazil? Do you have access to allografts, or no? And
no, Brazil is not allowed to use any kind of allografts, so we don't use allograft in Brazil. We pretty much use, besides autologous bone, which is very popular, of course. We use xenograft, and there are some companies now developing some synthetic material as the some patients are starting to request something not coming from any kind of animal. So there are some holistic,
Yeah.
things going on right now, I think, worldwide, and a lot of patients would claim that this kind of biomaterials like xenograft or allograft or, not coming from him all on might produce some problems systemically, which I don't believe, of course. But because of that, the companies are starting to develop some synthetic materials to overcome this kind of source, related to the patients.
So you see that as kind of a trend, a little bit towards, a little bit more towards alloplast or a synthetic?
That is pretty much related to this kind of situation that I just mentioned.
Your market, yeah.
But to be honest with you, I tried some synthetic materials. Although they were effective, I still think that in my hands, when I see the quality of the bone that has been regenerated, there's a small trend to see a better outcome in terms of the xenografts as opposed to synthetics. But it's growing, and as we learn how to manipulate these materials, because the handling is a little bit different, I'm starting also to have good outcomes as well with synthetic materials.
Okay, good.
But I think in the near future, because of this kind of holistic situation, I don't know if that is the name, more and more people will be, going to that direction as well. So I've been using those materials as well here in Brazil with good outcomes, but I'm learning how to, manage with those.
Okay. Hey, and if anyone has any questions for Dr. Carvalho, if you can put them, in the question. There's like a speech bubble with a question mark in it. At least that's how it looks on my screen. If you would put them there, then I'll make sure that we get your questions asked. So Dr. Carvalho, there's I know that in your cases, what I've seen is you like to use, or you did like to use, it could change, a tenting screw, kind of as a marker to sort of decide exactly how much height you want in these vertical ridge augmentations. Are you still using a tenting screw? What is the value of it? How necessary do you think that it is? Because I've heard both sides. Like, I've seen great results with tenting screws. I've also heard others say, hey, you can use them, but not really necessary. So what's your thoughts on that?
So yes, very good question. And that has also been changing through time with me. So in my beginning, I use tenting screws for horizontal and verticals. But after I learned the skills or the synergy of the membrane and the biomaterial beneath the membrane, like the sausage technique, I saw that I didn't need to use the tenting screw for the horizontal. And I kept using them for some time for the vertical augmentations, because they kind of create, a reference for the membrane to be wrapped on that area. However, through time, I could observe that whenever I had a problem in my vertical augmentations, it seemed to me that where the tenting screw was positioned is exactly where I lost more of the bone augmented. Then I felt that the tenting screw, if there is a problem like an infection or because of the adhesives, might be leading bacteria around that and leading for more bone loss. Because of that, and because I've been gaining more experience in terms of the sausage, so to speak, technique, in which the membrane is going to be stabilized by the packing of the bone beneath that membrane, I started not using the tenting screw for anything. And it is interesting to note that my problems in terms of bone loss, if I have some kind of exposure, for instance, dropped very much. So I don't use or recommend using tenting screw for my students anymore.
I think that goes into the concept of, the more things you put into a site, I've heard this described before, the more things you put into a site, the more potential complications that you have.
Yeah.
And maybe that one additional thing, more surgical time, et cetera, perhaps that played plays a part in
Yeah,
that.
and let's see, but anyway, in the beginning, or for those who are not so experienced, I do think that the tenting screws are important because they serve as a reference
Yeah,
for the clinicians to fold the
yeah.
membrane on the area, not only on the horizontal but also on the vertical aspect. But again, after you learn how to trim the membrane and position the membrane and start to play with the synergy of the bone graft and the membrane, you don't need that anymore. So I've been not using that for some time, and my outcomes parallel to that are much better right
So
now.
for beginners, maybe it's a good idea to start with the tenting screw to
Yeah,
start
until
figuring out
they
how to
develop the skills.
three-dimensionally
Yeah,
build out the desired ridge
yeah.
dimensions, and then perhaps over time that could be
Until
phased out.
they learn the skills, and eventually they will see that it's not so important to be used.
Gotcha. Um, what about treatment times? How fast, if you're doing let's say horizontal or vertical, and maybe these are different time points, how long are you waiting to go back in and place your implants?
So that is very straightforward as well. So whenever I'm doing horizontal augmentation, I'm waiting like 6 months to re-enter the site and place the implant. But when I'm doing vertical, I'm waiting a little bit more because of the dynamics of bone formation in those more demanding sites. So I wait like 9 months, eventually 1 year to reopen the site. I have been seeing a lot of people, colleagues of mine from Europe, for instance, they have the tendency to reopen the site a little bit too quick, like 6 months, for instance, in a vertical augmentation. And I saw those cases, I've been seeing those cases, and I have the feeling that the bone seems to be too soft at that moment.
Okay.
And they say that by placing the implants in a softer bone, okay, that will not put so much stress on the bone, and it may take the advantage of the placement of the implants to perform another, healing events and, have a better outcome. But to be true, I don't like too much that idea. I prefer to wait a little bit more until the bone is really stable and hard so that I can place the implant in the best scenario possible. So my preference is waiting a little bit longer for the verticals, and horizontal, like 6 months, should be okay.
Okay. Yeah, thanks for that. So are you using any of the newer product by Osteogenics, the reinforced PTFE mesh, which is basically the titanium reinforced, but with like 0.66 millimeter diameter macropores? Are you using any of
Yes.
that? If so, some clinicians, for example, talking to Dr. Isfan Urban the other day, he was saying that he's able to go back in a couple months earlier. Are you using any of that? And if so, are you seeing that you think you can go back in earlier, or are you still sort of cautiously seeing, if there's a change in your treatment protocol?
I have a good point on that. And indeed, I'm changing to that membrane because not because of that, of re-entering faster, but I felt that the handling of that specific membrane is much better to be used as opposed to the titanium reinforced, cytoplast material because of the density of that. So as you know, the cytoplast, they have two thickness, 250 and 150,
Yeah.
but the mesh is 200 microns thick. So it's like in between. So I really I don't like the handling of the thinner one, and sometimes I think that the handling of the thicker one is a little bit too difficult, but the intermediate one is much, much better in terms of the handling. So I'm very easily can elevate or lift this one side of the membrane and pack more bone, so I can observe that the shape of the ridge that I can recreate seems to be better because of this handling of that. But I haven't reopened the sites earlier to be sure of what's going on there. But as I mentioned to you, I prefer to wait a little bit longer because I feel that I'm more comfortable with that, and the quality of the bone might be very good. That's it.
Okay. We had a question from the audience. It's actually a implant dentist here in Lubbock, Texas. I'm asking you about when you're harvesting autogenous, where are you getting it from? How are you harvesting it? What are your recommendations there?
So if I'm working the mandible, for sure that I'm working here in the posterior mandible, I'm taking from the ramus. If I'm working here on the anterior mandible, I'm working here on the mental. And when I'm working on the maxilla, if I don't have a very big defect, I try to open a little bit more and scrape the bone with the micros in that area. So I don't have to necessarily reopen the mandible of the patient to do that, because there's a lot of bone there. We can take some bone from the tuberosity as well on the maxilla. So generally speaking, when I'm working in the maxilla, I try to harvest the bone from, adjacent areas. Of course, eventually having to open a little bit longer flaps to achieve that goal. And when I'm working on the mandible, I prefer much better using the auto chip maker burrs, because I feel that they are faster as opposed to the safe scraper. But if the angle of the safe scraper of the ACM is not so good, then I'm using the safe scraper as my second choice. In the maxilla, the micros, because of the way it goes. In the mandible, first option ACM, second option safe scraper.
Okay.
And the amount of bone is like eyeball. I have my visual well set already, so I tend to take a little bit more bone, as I mentioned, like 75%, 60% of autologous bone, depending on the dimensions of the defect.
Okay. Great. I always like to ask this question, well, and maybe this is more for ridge preservation. But well, let's ask that. So ridge preservation. We know graft material for when you're doing ridge augmentation, it's some mix of autogenous and xenograft, but you're going like 60 to 75% autogenous. For ridge preservation, what material are you using?
For ridge preservation, we're using exclusively biomaterials. Mm-hmm. We don't use autologous bone here in Brazil, or in my decision tree protocol. We do not use any other material rather than the xenograft here in Brazil, or the synthetic material, as I mentioned. I know that in the US you use a lot of allografts for that purpose, sure, which is very good. I have a lot of friends in the US, a lot of teachers that they can show beautiful cases. But regardless if it's allograft or xenograft or synthetic material, I really don't think it's necessary to use autologous bone in the socket preservation procedure, because it's within the boundaries of the socket. So it's pretty much a favorable defect to be filled. So that's why I don't use autologous bone there.
Gotcha. Makes sense.
Yeah.
What about membrane? What type of membrane do you use in that case?
So if I have like a completely missing buccal wall on those cases, I generally perform like a pouch in the buccal area. I don't elevate a flap, but I create a pouch in the buccal area, and I place a membrane, a resorbable membrane on that regards. And then I close the socket, or seal the socket with a collagen matrix, for instance, although that I know in the US is very popular to use the cytoplast to do the socket preservation, which is very effective. Some people here in Brazil are using that too, but I feel very comfortable using resorbable membranes after I tuck them in on those defects and socket seal with collagen matrix. So
closure or exposed?
No, exposed. So no primary closure, because especially in those situations, statics is very important. Yeah. So and I think that's a mistake to try to close completely the tissue, because if you do that, you might you might create a better environment for the regeneration for sure, but that creates a deviation in the mucogingival line. So in the time of the implant placement, we may have some problems to put it back and recreate the aesthetics as well. So we don't try to have primary closure on those socket grafts.
Okay. Yeah, that's the same reason, with the cytoplast technique that it was developed is to, with purposely leaving it exposed is to preserve the soft tissue architecture and
Yeah.
increase the thickness, the width of the keratinized tissue band. So it makes sense that everything you're saying makes perfect sense to me. Do you ever mix with antibiotics?
Say that again?
Do you ever mix the graft with antibiotics?
No, no, no. We may do that. A lot of people would use metronidazole for doing that. I think it's perfect, fine, no problem with that. But I rely much more on the curettage of the defect, and I just place my biomaterials there. If there is a previous infection, we might think about, adding some kind of antibiotics there. But that is not the standard for me, for instance. I know that many people do that without a problem, so there is not a dwell with me with that. I think that doesn't make a change, make a difference, but I don't do it.
It's interesting. I feel like when we asked that question 15 years ago, like half the people would say yes on the antibiotics. I've asked that question to several of our guests here on our Q&A sessions, and I can't remember the last time that somebody gave me a yes on the mixing with antibiotics. I feel like maybe that's one of those things that's kind of been proven to not be one thought. And also, I think what I normally hear is just heavy, like very serious cleaning out of the socket, aggressive there, but then not needing antibiotics after.
Yeah, so and if I see a clinical scenario that I'm not comfortable putting the biomaterial there, I just wait and reopen the site later on to do like a GBR procedure. So it turns out to be not a socket preservation, but a GBR procedure. Mm-hmm. So if the time of extraction I'm not comfortable, placing anything there, I wouldn't rely on the local antibiotics to clean the area thoroughly. In that regards.
Gotcha. And we got a little bit of a late start. I think we'll probably go till if you have let's go 7 more minutes till 7:40 my time.
I have 2 hours if you need. I'm always yours.
At some point I'm going to need to eat dinner, so okay, so 2 topics. One is peri-implantitis is something that I always like to ask about. When do you decide to try to save the implant versus extract and come back later, or extract and replace?
$1 million question. That is the $1 million question. Yes. So that is very tough to answer like easily, because it depends on many aspects. It depends on the size of the defect created around the implant. It depends if if we have like a crater kind of defect with walls and bone peaks around that area. It depends how much bone we have lost in that situation. It depends if we have adjacent teeth versus implants in that area. It depends the quality and quantity of the keratinized tissue, if there is, around that area. It depends if the height of the implants, the characteristics of the implants. So it's a very tough, it's very individual, case-by-case selection. But one of the most difficult aspects of treating peri-implantitis, as you know, is the decontamination of the implant.
Yeah.
Indeed, I have been very successful in the treatment of some peri-implantitis cases. I've been collecting a very good amount of cases in which I feel that they are good for regeneration in terms of the anatomy of the defect. And when I see that with the height of the soft tissue preserved, I open the site I clean the implant surface very well using Teflon inserts of piezo device, but Teflon, like plastic inserts. Use the jet of glycine. Use like some called mechanical debridement. Use like using rotary, instruments. And then I've been using laser, the high power laser, erbium laser, to decontaminate the surface of the implant. And of course, a lot of irrigation and everything we can do. So as much as I can to decontaminate the area the best way possible. And from that point, I do like a regeneration, a regular regeneration on top of that. So sometimes using resorbable membranes, sometimes using titanium reinforced membranes. If you allow me, I'm going to send you later one of my most recent case.
Okay.
That I had like 2 implants sticking outside of the bone, but with adjacent peaks, and I used a cytoplast to regenerate that area after doing this kind of peri-implantitis therapy, the cleaning of the implant. And I've used an autologous bone, I use a xenograft. In that case, I think I also use biologics like GEM21, okay, and LPRF covering everything. So I used the whole package, and I closed the area completely. So I took out the crowns and completely sealed the area like for primary closure, and waited 6 months. And last week I was amazed to reopen the site and see the completely rebuilt bone, as if it was done of the same moment. And other cases, of course, that I have like that. But the biggest challenge is really to understanding the anatomy of the site in terms of the bone and soft tissue, and how much we can grow on that area if we are able to decontaminate the implant very well.
Okay.
I can send you that case later on, and you can publish on Osteogenics, whatever.
That'd be awesome. Yeah, thank you. I'd love to see that. Let's do that. Last question is soft tissue grafting. Are you using, so allografts are not available in Brazil. So are you using all autologous grafts, or are you also using some the newer xenografts that are available? What's your go-to material for let's say like recession defects?
No, for sure, autologous bone, autologous soft tissue graft from the palate, from the tuberosity. Some cases like root coverage around teeth. If I do have some amount of keratinized tissue adjacent to the gingival recession, on those cases specifically, I might consider using collagen matrix because they seem to be working when I have some keratinized tissue, and when I don't have too deep gingival recession, if the recession is not too deep. But other than that, for sure, I still rely on the gold standard connective tissue graft from the palate or from the tuberosity. Around the implants, I like to use the tissue from the tuberosity. Around teeth, I like to use the tissue from the palate, sometimes taking the connective tissue itself, sometimes taking the free gingival graft and de-epithelializing it outside the mouth and using the so-called lamina propria. So pretty much depend on the case.
Gotcha. Do you normally use like a tunnel, a pouch, or a flap?
So excellent question too. That's a very big debate going on internationally right now on that regards. And in the anterior zone, I try to use as much as I can the tunneling approach.
Tunneling.
Because especially when we have thin papilla, some people that shows, like very important international speakers that I see all the time showing those root coverage cases, they don't call the attention to the fact that sometimes by opening the regular flaps to do the root coverage, they do cover the roots, but they lose the papilla tip sometimes. And that is related to the size or the shape of the papilla when it's very thin and narrow. So whenever it's possible, especially in the anterior zone, I try to go as much as I can to the tunneling procedures. When I have any kind of interproximal bone problem, for sure, a tunneling procedure. And in the posterior zone, in which is not being completely observable when the patient is smiling because of the height of the smile line, then I can do those flap procedure with the incisions, the base of the papilla, because it's much faster, and the posterior area is a little bit more difficult to do the tunneling procedure because of the anatomy of the bone in that area. So doing the tunneling in the posterior may not be so easy because there's a tendency that eventually can perforate the flap on that area.
Awesome. Hey, I appreciate your time and all your answers. Time flies. I think we've gone through our 30 minutes. I do want to talk about your courses. So I know that this is something, you had a U.S. group there just last week. One of the doctors sent us a picture with you. I think he was very happy with the experience. So you're doing courses in Brazil. Is it in Sao Paulo or is it in, where are the courses, and how often do you do them? What topics do they cover, and how do we get more information?
Well, yes, we do have several clinical courses going on here in Brazil, in which American dentists, European dentists, they come to visit us for clinical training, and it's like a week time course in which several topics are covered. But as we are like a private group, so we can do whatever you want. So the group, they can request much more soft tissue management around teeth. Other groups, they want specifically to do GBR and study GBR and soft tissue management, peri-implantitis. So we can cover it all. So if people are interested to know a little bit about our work, we are at implant perio right now, so we can send us a message. I'm pretty sure that Osteogenics can also send some information to those customers, and from that we talk.
Awesome. Yeah, I'll we'll post this video once it's done, and I'll put a link to your site in the caption there. Well, thank you so much for your time. I really appreciate it. Appreciate your friendship over the years and the collaboration. Always very open to share your ideas and your results and your concepts. I really appreciate it. So thanks everyone for joining us. Hope everyone has a great evening, and we'll do this again soon.
Thank you very much, and thank you everybody for being here. And I apologize again for my delay. Bye bye.
Thanks, Robert. Bye.